I want to ask you a bunch of questions. And I want to have them answered immediately.
That's vodka.
You want answers?
I think I'm entitled.
You want answers?
I want the truth!
There's a good chance I'm going to have some carbonaceous sputum.
Hey, I never asked you.
Yeah.
You like guacamole?
Hey everybody, Mike and Jared coming back with you. I'm sure you probably noticed a little bit different background. I am enjoying a nice vacation, temporarily relocated RSI Podcast studios to northern coast of Michigan. So I apologize for any of the background. If you don't enjoy that, I'm sorry. Looking forward to giving you episode 17 today. We've got some great questions. Jared and I will be solo, just the two of us. No guests this time, but we'll be bringing a guest on next time. As always, we're ready for more questions. I'll put a link in the show notes, RSI Podcast at foamfrat.com. You can find us there. You can email us, RSI Podcast at foamfrat.com. Look forward to hearing from you. Enjoy episode number 17. All right, Jared, question number one coming at you. I've heard several paramedics talk about their experiences with intubating airway burns. A common thing that I tend to hear is that the airway was swelling shut in front of me just before I passed the tube. How much do you think the process of intubation exacerbates the already inflamed airway?
I think we could all go with the same assumption. It is going to exacerbate airway swelling. And I really couldn't find or come up with a specific answer, or at least an evidence-based answer myself. I actually talked to a doctor about it, and he kind of gave the same answer that I had in my head. Well, yeah, of course it's going to exacerbate the already inflamed airway. And so I guess really if you think about it, it's, there's already laryngeal swelling. The airway itself is inflamed. It's sensitive. So sticking a blade in there, an ET tube, suction device, whatever it may be, is going to exacerbate what's already swollen. I think that makes sense. But to put it into like maybe kind of a perspective, Mike, and I assume that you've been through this scenario before where somebody's intubated a patient or attempting to intubate a patient, their first step. And for whatever reason, they can't view the cords. They can't get the tube to pass, whatever the situation may be. Then you get handed the laryngoscope blade, you get handed the tube, and then you go in to look afterwards. And then the airway itself is just full of pink tissue pillows, and it's hard to identify any landmarks in general.
That happens even when they're not burned.
Yeah. And that's exactly my thought is like, if they're burned, that airway is extra sensitive. I would expect it to swell even more with any bit of laryngeal manipulation that we're doing ourselves. But yeah, and I've heard that adage before by other people, maybe not necessarily swelling shut in front of my eyes, but I've heard something along the lines of, if it had been another 15 minutes, that airway would probably be closed, or it would have been, we would have been going for the knife. So I haven't intubated an airway burn myself. The closest I've got is a smoke inhalation, and it was just an airway full of soot and honestly wasn't swollen. So I've been fortunate. What about you?
Yeah, and those just straight up smoke inhalation, oftentimes they aren't going to be exposed to a lot of heat. So there's not necessarily that transfer of heat energy that's gonna cause those burns. I have seen what I'll say to be a decent number of burn patients that are likely intubated unnecessarily. The patient that has a burn on their forearm and maybe some flash burns coming up their chest, but no burns on the outside of their face. It's tough to say, well, I got to take that airway because I don't want it to swell shut. And I've transferred patients like that had already been intubated. And it's like, well, we had to, we intubated because we found, we scoped them and we saw some carbonaceous sputum in the back of their oropharynx. I'll tell you what, I wear my air pack most of the time, like through overhaul and stuff. But if you see me coming out of a structure fire, there's a good chance I'm going to have some carbonaceous sputum coming out of my nose. So I hope that they don't intubate me. But that's what we've got to understand when we use that as a deciding factor. What kind of burn did the patient sustain? Were they one of those outside at a campfire and were dumb and threw something on it, had a little flash that came up? odds are they're not going to get a lot of heat transfer into that airway. So I think it's something that we just need to be mindful of. And I'm going to link a study to go along with this. That it was an older study and it was retrospective. So it was 2003 to 2013. They looked retrospectively at burn patients that had been intubated and determined that almost a third of them were likely intubated unnecessarily. So it was interesting to read. Like I said, there are some limitations. It's older data and it's retrospective, so we have to take that for what it is. But they made some recommendations that I thought were interesting, talking about signs of airway obstruction, hoarseness, stridor, accessory respiratory muscle use. Those times when we're ordinarily going to intubate, of course, those patients are going to need to be intubated. High body surface area burns. Burns inside the mouth, significant edema, things like that. They're all good reasons to intubate our burn patients. But something that I think that we don't think a lot about is what's happening with the fluid shift in these burn patients and what's happening when we over-resuscitate with fluids pre-hospital. Because remember, we're always told, oh yeah, they're burned, you got to give them a bunch of fluid. Well, that's not necessarily the case. So I'm going to give you some real quick numbers, and then we're gonna move right along. So let's say, hypothetically speaking, we have a 70 kilogram patient that's burned over 30% of their body. So 30 times 70 times 2 to 4, if we're using consensus, Parkland is 4 cc's per body surface area per kilogram. So that exact patient, almost a third of their body burned, 70 kilograms, would get 4 to 8 liters, depending if you're using consensus. So if you're using the 2 to 4 cc's, 4 to 8 liters roughly. That's in the first 24 hours. They're only getting half of that in the first 8. So if we divide that in half over the first 8 hours, it's only 2 liters. You know what that is per hour? Probably in the pre-hospital phase, it's 260 cc's. So think about that burn patient that we dump bilateral 18s in, and they've got 2 liters by the time we get them to the hospital, and what that's doing to the edema that we're likely going to experience. Couple that with the fluid shift from burns, and I think that's where some of that airway swelling comes into play. And some of the American Burn Association findings were kind of along those same lines. And I'm going to link some information that you can kind of nerd out and read more on it if you want. But Jared, did you have any other thoughts? Because we're kind of getting close. No. I'm sorry, I ate up a bunch of time there. I wasn't planning to.
No, I think it's huge that even just the fact that you did that math and pointed out that it was 200 and whatever mLs per hour. I know a lot of the new guidelines are going towards like, don't even do the math anymore. Simply put 500 mLs per hour and transport. That's how you'll transport in the acute or the initial phase of treatment of those burns. And I think that just speaks volumes to, 500 mLs an hour. That doesn't sound very fast. I've been putting 2 or 3 bags, dropping in as many lines as I could and giving as much fluid as I could in the past. And then you go, oh, well, I may have messed up.
Yeah, I do. I like the 500, 250, 100 that some folks use. So 500 for adults, 250 for children, and then very small children, 100 in that pre-hospital phase to kind of cognitively offload that calculation. Because I agree. Mm-hmm. I don't think a consensus or Parkland calculation is important pre-hospital. Unless you're getting ready to take an advanced certification exam, then you're probably going to want to know those formulas.
I was just thinking the same thing. National Registry, you have to know those numbers.
Yeah, they think it's very important. But yeah, 500, 250, 100, if your protocols allow. Remember, Jared and Mike do not have unlimited licenses to practice medicine, so you got to pay attention to what your medical directors say. But that's just my thoughts.
All right, so question number 2. The listener asks, or really I should say the listener put, I'm interested in hearing your understanding of auto-PEEP. I've learned quite a bit over the past few years, but still have a hard time understanding the concept, especially how it relates to external PEEP. My brain has a hard time understanding why lowering extrinsic PEEP in the setting of elevated auto-PEEP would be harmful rather than helpful. I know that the theory of raising extrinsic PEEP to 75% of the auto PEEP has been disproven in the acute illness and is only really helpful in weaning patients off of the vent to allow them to trigger a breath. I would be interested in hearing your understanding and maybe a review of your threshold for treatments for a patient with high auto PEEP.
All right. So this was a great question, and I'm really glad that they asked it, because it really allowed me to dig into some things that I didn't have a great understanding of, and I'll get into that a little bit. I'm going to quickly go through the auto PEEP thing though that they're asking. So ordinarily, we take in a deep breath, we exhale. That exhalation stops because the pressure's equalized, right? The pressure inside our lungs equalizes with the pressure of the atmosphere. That's why the flow stops. I have to kind of break some bad news to you. There's no intrinsic PEEP in a normal,
Thank you for saying
physiologically responding patient. There is some sort of underlying pathology if there is positive pressure contained in the airways at the end of exhalation. That is auto PEEP, or some people call this intrinsic PEEP, but intrinsic PEEP is not a normal finding. There's some sort of pathology at work there that's causing us to retain a positive pressure at the end of exhalation. So very simply, that is auto PEEP. So within those, the internal portions of our airway, we're retaining pressure. We're not getting to zero. We have an auto positive and expiratory pressure. So something is causing that. So there's basically two divisions in auto PEEP. You have auto PEEP with some sort of intrinsic expiratory flow limitation. So this is like your emphysema COPD patients. They've got a breakdown of alveolar function that ordinarily holds those airways open. They've lost that, so they trap air in there, and they can trap positive pressures within those lungs. So think emphysema COPD patients, and these people with auto PEEP will help them, because it is that PEEP that can help to kind of splint some of those airways open and maybe help them to evacuate some of those positive pressure areas. So PEEP within reason is indicated and can be helpful in the patient that has that intrinsic expiratory flow limitation. So if they're auto PEEPing, if they're building pressure, but they don't have that pathology, they don't have that intrinsic expiratory flow limitation. Think of patients like small endotracheal tubes, or endotracheal tubes that need suctioned, maybe a short E time. We've got too high of a rate where we're not giving enough time for expiration. A blocked exhalation valve, or you've got a PEEP valve on that's become blocked somehow. So this is positive pressure that's building up, or auto PEEP that's building up without that intrinsic flow limitation. So that pathology is not there. And these patients, that PEEP is not really going to help them, because that's the problem. We're not allowing them exhalation. There's something mechanically or physiologically that's not allowing that to happen. So PEEP's really not going to help them a whole lot. So what I like to do, and I'm just going to throw this out there really quick, and then I'll throw it to you, Jared. So I use the Hamilton T1. I like to leave the pressure volume loop up. So I'm able to look at that pressure volume loop, and I'm able to see, is that loop moving right along the pressures? Are my pressures not returning to the place that they did in the previous breath? So it shows you the previous, and then it shows you your new loop. The nice thing is here, you can also evaluate changes that you're making with PEEP or with other settings, pressures and volumes and things like that, to see past that upper inflection point. Am I getting beaking in that waveform, or am I getting a return on my investment? I'm increasing pressure, but I'm getting more volume that I wanted, and I'm not moving right. I'm not increasing pressure. So that waveform in and of itself tells you so much, and I think it's really valuable, and I think it's underestimated. So Jared, I went on. What do you got?
No, I don't really have a whole lot to add to it. I look at it the exact same way. If I were to dumb it down, to the best of my ability, and it's not all inclusive. I go, when we look at auto PEEP, I'm always like, is it the patient's fault or is it our fault? And that's kind of how I explain it to, and say some of the newer providers that we get. And they're like, well, what do you mean by that? And when I say it's the patient's fault, it's usually a COPD or asthma, and PEEP is going to assist with that. Like, we are going to add something to it to stent those lower airways open. Just a little bit of PEEP sometimes is more than enough, but it'll stent those lower airways up and allow them to exhale. Now, if it's our fault, maybe it is our E time is too short. Our there's something wrong with our I time. Maybe our respiratory rate's too fast, or maybe it's a sedation issue. I look at it in those two different veins. Now, one of them is going to benefit from PEEP, and then the other one is not. So when it's the patient's fault, a little bit of PEEP should assist them. When it's our fault, oftentimes we have to look at maybe our parameters, or our numbers, or our sedation level in order to identify what the potential issue could be. And then you just kind of go with a generalized treatment for it. If you have auto PEEP and you're unsure of what the problem is going to be, you do the typical, potentially reduce your respiratory rate, increase your I time, reduce your respiratory rate, decrease your I time, increase your E time, bronchodilate. Maybe you can consider giving epinephrine or magnesium, treat the condition at hand. But, I guess really depending on which side of the court that you're on there, I don't think a little bit of PEEP is too incredibly harmful. You just need to run through and critically think it through and identify what the problem is and attack that first.
Yeah, and I agree. I think, especially trying smaller amounts of PEEP and seeing what happens, because you can very easily have a mix of both of these, with and without expiratory flow limitation intrinsically. You can have an emphysema COPD patient that also needs suctioned. So,
right.
Given that, if you've mixed the two, now you've got a dichotomy there where you've got to make some decisions, you've got to make some treatments, you've got to see what happens, and I think that's where use of that waveform can be useful. Something I did want to throw out there real quick, and then I know we're getting kind of long on this one, but because this could be a whole podcast in and of itself.
Right.
But I use the Hamilton T1 ventilator. I used to use the Ravel. So obviously in the Ravel, I had I holds and E holds, so inspiratory holds to check P plats and expiratory holds to check PEEP. Well, I don't have those maneuvers on the Hamilton T1, right? So this is the portion that I was really glad that I got this question, because anytime you get questions as an educator, it makes you want to understand something more. At least it does for me. Sure. It's like I've got to know the nuts and bolts, absolutely every bit of this, so that I can explain it. And I never really dug far enough into how the Hamilton works when it comes, because it'll give you an auto PEEP number. You go to page 3 in your monitoring parameters, or at least the way our events are set up, it's page 3, and you'll get an auto PEEP, but there's no expiratory hold. So how does that work? So it uses Hamilton uses what's called a least squares fitting method. So it's a statistical analysis that basically calculates that positive end expiratory pressure, or the auto PEEP that you have. So, and this is straight out of Hamilton's manual, and I found some studies that backed it up as well. Spoiler alert, I think there's going to be a blog coming on this. But actively breathing patients can create artifact or noise which affect the accuracy of the measurements. And the measurements that they're speaking to specifically are inspiratory resistance, compliance, and auto PEEP. Some pretty important numbers that we're using, right? That in the Hamilton are calculated. And I'm not saying that's bad, but you have to understand that the accuracy of the measurements can be affected in actively breathing patients that have that artifact. They say the more active the patient, the less accurate the measurement. To minimize patient participation during these measurements, you may want to increase pressure support by 10 centimeters of water. After completion, return this control to the former setting, straight from Hamilton. So that was something that I was unaware of. I hadn't seen that. So that's why I was really glad I got this question. Really glad I had to dig a little bit further into it, and I think I'm excited that I think I'm going to have some more things to say.
Yeah, and I didn't know that bit of information either. And then I remember discussing it with you just yesterday, day before yesterday, whenever it was, and then we kind of had mistaken what a word for P-plat, but then the Hamilton is just so advanced. It knows how to do these things. Because in my head, I'm like, if there is no expiratory hold or there is no inspiratory hold, how the hell is this device getting it? And is it just an approximation, an estimation number? Is it accurate, or is it just something for me to trend? And and then with you digging into it, I've definitely learned something about it as well.
All right, question number 3. Jared, this one's coming to you first. Hey fellas, new flight clinician here. I know you guys have already been asked several questions about being new to flight, but I have been told as a nurse my medic will take care of the vent during calls and flights and not to worry about it. Is this the case where you guys are? Should I prioritize learning other things?
So kind of makes me giggle, not because it's a bad question. I'm never, none of these questions have ever been bad. It makes me wonder who the hell the medic is that told the nurse this little bit of information. So you were told that the medic's going to take care of the vent during your calls and your flights. And then I guess, I don't know. What is the service you work for? Maybe you're with the same medic for the next 3 months, every single shift. So yeah, maybe you could prioritize that and allow them to take care of it. But most services, flight services, even ground critical care services, I don't know that to be the case. So I'm going to say, yes, you do need to worry about it. And it's definitely something that you need to learn, but I think it's a system by system basis too. Some programs are going to use the vent more often than others. Now, is this the case where I'm at? Absolutely not. I would say I go out of my way to make sure that the nurses, if they lack in either airway, cardiology, or mechanical ventilation, that I'm going to get them to a spot where at least I feel comfortable with them. I could just hand them the vent or the cardiac monitor, whatever it is, and let them do their thing. Now, should you prioritize learning other things? I'm going to say learn it all, and to the best of your ability, dive into everything that you're going to be utilizing on a regular basis. Should you prioritize other things? Like I said, it's a service by service thing. So maybe you don't utilize the vent as often, and maybe your partner wants you to learn other things first. I'm not completely against that, but I would say that you should worry about it, but to what degree, I guess, would be the better question. What about you, Mike? What do you think?
Yeah. So when I read this, I also giggled a little bit, and I kind of shook my head, and I'm like, oh gosh, this hurts. But the thing of it is, what is so important in this industry, and I'm not talking about just flight, I'm talking about public safety in general, is that you're hungry, that you want to learn, and you want to know as much about everything as possible. So I think statements like that, saying, "Hey, the medic takes care of the vent, so you don't need to worry about it," I think those are dangerous, and I think potentially damaging to that person's development. The person being told that information. So absolutely, the service that I work for. So we fly nurse medic, and the vast majority of the time, I'm running the vent. I'm taking care of the airway. So I utilize the vent most of the time, but every nurse that I work with knows how to use it, and they need to know how to use it. It just like, it would be like saying, well, you're the medic, so you don't need to know how to run the IV pump, or you don't need to know how to draw up medications, because the nurse generally does that. So yes, we have role designation and lanes that we generally stay in, but those lanes cross over so frequently that to say that you don't have to know that other person's lane is very, very inappropriate, because you 100% do. The easiest part about a ventilator, in my opinion, is being able to push the buttons. I mean, we could train a monkey to do that, but being able to critically think through mechanical ventilation is absolutely your lane, whether you're the nurse or the medic, because there's so many things going on there, and you can help your partner critically think through what's going on with your patient. if you have a good understanding of mechanical ventilation. You can talk intelligently about what kind of alterations may be made in settings depending on what's going on. So there's so much that we do. There's so much that we do together that to say that you don't need to know that portion of another person's job is just wrong. It's just wrong. And it's not uncommon at scene flights. The way we operate, our nurse will leave once we know we're ready. Once we know we're going to load the patient, the nurse will leave and go prepare the helicopter, and the medic's responsible for facilitating that transport of the patient to the helicopter, working with the ground services that are there. So 9 times out of 10, if that patient's going on the vent, when I get to the helicopter with the patient, the vent's out, set up in standby mode, ready to go. So I think it's very, very important that you know the entire part of your job. You could have a multiple patient scenario. I know a lot of flight services don't fly multiple patients. The service that I work for do. We're fortunate. We have a large aircraft. We're configured for two patients. So you talk about herding cats. Try having 2 patients in the back of a helicopter, and trying to manage all that. Now couple that with you only knowing one part of your job. It's just not gonna work. So I'm pretty steadfast in that.
Yeah, I'm in agreement. To, like, just imagine how toxic, or at least in my head, how toxic that maybe this specific paramedic is. And I don't know.
I want to know what has the paramedic decided that they don't need to know.
Right. And that's exactly it. It's just a toxic attitude to have. What's it, inferiority complex? Maybe something along those lines. But the other side, what if you don't teach that nurse? So where I work, I could go to multiple different bases and work with multiple different people I've never met before. And, while not ideal, it happens. And what if 2 nurses get paired up and they both had shitty, toxic paramedic partners that had that same ideology? And now we have just 2 people who have no idea how to do a handful of things because somebody bossed them around, had that crappy attitude about it.
Yeah. Now we've got a big problem, right?
Right.
So everybody, thanks for being here. I hope you enjoyed the new setting of the RSI Podcast studio that I have behind me. You'll see that Jared's is still the same. I'll be back to my old studios for the next episode. So get your questions in. We're excited to hear from you. We've got questions carrying over that we weren't able to get to this time. So if you'd submitted your questions and you didn't hear them answered today, we have not forgotten about you. We're getting to you. It's really exciting to see the momentum pick up, and we're getting more and more questions. So keep them coming, and we'll keep getting them answered. Thanks again. We really appreciate everything that everybody's putting into this podcast. Have a great day.
I'm in agreement.
Coolio.
Cool. That's vodka.
All right. So the next one is Peep, right?
The next one is indeed. All right. So I was about to say, no. I was about to say question number 5, and then it would have been super, super confusing for the listeners. Wait, where were the other 2 questions? All right. So, yeah, I guess it could go either way. You want to read it to me? Sure. I'll let you read it to me, Mike. Story time.
Yeah. Okay. All right. Story time with Mike. All right. Cool, man. Well, I'm showing 29 minutes. So I think we'll probably wrap it up because it's going to take a while for this to upload at the upload speeds that I'm dealing with on the dial-up internet up here. So I'm going to do a real quick outro, and then we'll get them uploaded.